occipital lobes. In fact, let's go back to our color-coded map here. One of the sensory areas we've already referenced. That's the primary sensory or somatosensory cortex. That sits along the postcentral gyrus. In green here, and kind of along the roof of the temporal lobe, you have the primary auditory cortex. This is the area that receives impulses for sound from the inner ear. And if we look at area 17 along the occipital lobe, this is the primary visual cortex. This receives visual impulses from the retina. So these would all be sensory areas. Somatosensory means that it's picking up sensory information from receptors on the skin, like for pain, touch, vibration, as well as from receptors on skeletal muscle, like for proprioception, stretch. Okay. Auditory cortex picks up information for sound. Visual cortex, sight, vision. So again, the sensory areas are located parietal lobe, temporal, occipital. Easy breezy. Okay. We talked about the primary somatosensory cortex. It's housed in the postcentral gyrus, parietal lobe. It receives information from receptors in the skin and proprioceptors in skeletal muscle. I've already alluded to the fact that the size of the cortical area receiving impulses from a particular region of the body depends upon the concentration of receptors present in that region as opposed to the size of the body part. And I showed you the homunculus, our friend Hal. Okay. Besides the primary somatosensory cortex, the primary visual cortex is another sensory area. It's located in the occipital lobes and receives visual input from the retina. And in fact, if you have damage to the visual cortex bilaterally, then you'll develop what's called cortical blindness. Even though your retina in both eyes is functional, you still can't see. It would be analogous to having a fully functional fan but having a problem with the outlet, so that when you went to plug the fan in, the fan didn't work. In a similar fashion, the primary auditory cortex is located on the temporal lobe and receives info for sound. Okay. The third type of area, cortical area, is an association area. These areas communicate with primary motor and sensory areas as well as other association areas so that we can analyze incoming information and act on sensory information based on past experience. Okay? An example of an association area is the prefrontal cortex. It's also called the frontal association area. It's located in the anterior-most aspect of the frontal lobe. So let's go back. Okay. This area here, 10 and 11, prefrontal cortex. It's anterior to both Broca's area and it's anterior to the premotor area. Okay. It's called the prefrontal cortex. This is where higher cognitive activity takes place. Whoops. I think I want you to go here. So it houses things like intelligence and personality, the ability to reason and perform long-term planning. It's responsible for abstract ideation. So if you had damage to this area, it would result in what's called a frontal lobe syndrome. Now let's go back. We said intelligence, personality, reasoning, abstract ideation. What is abstract ideation? Abstract ideation refers to the ability to give additional meaning to words or phrases or sentences. The opposite of being able to think in the abstract is concrete ideation. I'll give you an example. People who develop Alzheimer's disease lose the ability to perform abstract ideation. So if you ask them to interpret proverbs, okay, they can only interpret those proverbs in the most concrete of terms. My dad has Alzheimer's, okay? And so every time I see him, I'm always testing him. So the last time I said, Dad, what does it mean to you if I say, don't cross that bridge till you get there? He says, what do you mean? What does it mean to me? It's obvious. How can you cross the bridge until you walk up to it? You know, he can only think in terms of the concrete. Okay? In other words, the specific meaning of those words. He can't apply additional meaning. Whereas you and I would say it means don't worry about something until it actually happens. That's giving an additional layer of meaning. That's performing abstract ideation. Okay, so that ability is housed in the prefrontal cortex, as well as these other cognitive skills. One of the first persons I saw, I was doing a neurosurgery rotation my junior year of medical school, was a Vietnam veteran. He may have been like 24, 25 years old. And he came in with the worst headache of his life. Now, at that time in the 70s, CT scanning was new. But Charity Hospital had a CT scan. And so we brought him back to the CT scanner. It turns out he had a bleed in his frontal lobe that was secondary to a ruptured aneurysm. Okay? So the resident neurosurgeon brought him back, and he went ahead and did a procedure in which he clipped the aneurysm to prevent it from bleeding any further. But I remember that it took about 4 hours of surgery to reach the aneurysm and to clip it and to stop the bleeding. In the meantime, this prefrontal cortex was ischemic. And so, of course, he suffered damage to that area as a result of a lack of blood flow. The fact that blood wasn't getting to the area it was intended to get to. So, in any event, he survived the surgery. His name was Dan. And I remember when he came into the emergency room, he was in a lot of pain. He was very frustrated, upset, because he was in a lot of pain. But he made total sense. He was married. He had 2 children. He was very logical. And he had never had any headaches before in his life. So that's kind of that's the thing we worry about. When someone comes in with the worst headache of their life, or they've never had headaches, and they come in with now a severe headache, we always worry about a ruptured aneurysm in those cases. So Dan survived the surgery, and we kept him under anesthesia for about 48 to 72 hours. And about 3 days post-op, we started lightening the anesthesia, allowing him to waken. That evening, we were making rounds. And when you make rounds, it's like a parade. You have medical students and interns and residents and senior residents and chief residents and an attending physician. Okay? And so, in the meantime, Dan had gotten out of bed and was standing up. And so we all walked up to Dan and started to interview him. Okay, we're all initially very happy that he was standing and it didn't look like he had any obvious motor deficit. But right in the middle of our conversation, Dan squats down and takes a dump on the floor. Okay? Now, does that make Dan a bad person?
No.
No. He didn't realize that that was inappropriate. Okay? And so all these things that you learn as part of culture growing up, how to behave, okay, how to interact with others, that was lost.
So did he have to relearn it, or did he lose it forever?
Well, he ended up being institutionalized.
Okay.
Now, in fact, several days later on rounds, we went to find Dan, and he was nowhere to be found. He had taken his IV pole and walked right out the hospital in his hospital gown. He walked all the way to the quarter.
And no one...
Not realizing that if he left the hospital, that people would be worried. Okay, that he wasn't supposed to leave. No clue.
Were there phones back at this
There were
time?
phones.
Okay, why didn't anyone...
The police found him
Oh.
and brought him back.
Okay.
But he didn't have the ability
Just
to,
making sure.
to think ahead of time and say, well, gee, if
Just
I
use on the
leave
phones
here,
then.
I'm not supposed to leave, for one, and that people are going to be looking for me.
Mm-hmm.
No concept of responsibility as a patient. And so when Dan left, He ended up
How old
going
was
to an
he?
institution when he was 24, 25 years old. You know, so it was kind of a sad, sad story. But that's kind of typical of a frontal lobe syndrome.
So was there any way for him to relearn those things? Like I know that.
You know, sometimes, and it would be analogous to a stroke. The thing about neurons is they're amitotic. So when neurons die, there's no replacing those neurons. But when you have a stroke or like you have a bleed like this, some of the deficit that's created is not actually due to death of neurons, but temporary dysfunction, oftentimes because of edema and compression. So as the edema resolves, as in this case, as the hemorrhage and surrounding swelling starts to improve, yes, some function does return. But with respect to those neurons that have died, you can't replace those. That function is lost forever. So in the case of Dan, do I suspect that he ever got to a point where he could live independently? No. No. This, and by the way, at one point in history, neurosurgeons used to perform a frontal lobotomy where they would take like some type of surgical instrument and purposely damage the frontal lobe because they thought it was a cure for certain type of emotional and psychiatric illnesses. In fact, the oldest of the Kennedy clan, you know, we had a president named Jack Kennedy.
Yeah.
His oldest sister, Rosemary,
Yeah, I
had a
read
frontal
that.
lobotomy.
There was a People magazine on that. It was
And-
called The Lost Kennedy.
And up until the time of the frontal lobotomy, she lived at home. Once she had the frontal lobotomy, she had to be institutionalized. It turned out it wasn't a cure at all for whatever neuropsychiatric disorder she had.
Didn't they do them like to practice like? Wasn't it like a clinical trial? Not official, but didn't they do it to people in mental institutions?
Well, it was considered even then kind of experimental.
Mm-hmm.
So I'm not sure the circumstances there, but it was never, you know, it was, at one time it was considered experimental, but new, you know, people who were wealthy and who could afford it, you know, it was kind of a last resort. Of course, we no longer do this. But I always say, I'd rather have a bottle in front of me than a frontal lobotomy.
What?
That's just what plan was.
Alcohol,
Oh.
maybe.
Or medical unit. Okay. Now, another association area is Wernicke's area. Let's go back to our map here, our color-coded map. Okay. And we showed you before the auditory cortex. Well, behind it, 3940. This is Wernicke's area. It's where the temporal lobe meets the parietal lobe up here. And it's no coincidence that it's located right next to the primary auditory cortex. As the primary auditory cortex receives impulses for sound, that information is relayed to Wernicke's area, which compares that incoming signal to signals in the past associated with that sound, so that it can give meaning to those sounds. So that every time I hear the sound Victoria, I associate it with that person right there. Okay? So that's an association area. It allows us to interpret sounds, to interpret the meaning of words. Of course, if you have damage to that area, then you have what's either called a Wernicke's aphasia or receptive aphasia. And here's the way I remember the two. I don't get confused. This is Wernicke's area. This is Broca's. B comes before W. Expression. E comes before R, for reception. So I don't want you to, you know, if you're ever asked what type of deficit results from damage to Broca's area, you have to remember that it's an expressive, not a receptive. That B comes before W, E comes before R. That's just my little mind, how I remember it.
Abby's throwing things.
Really? I mean,
Okay. I said that you were throwing
What's
things.
interesting is that when someone first presents with a receptive aphasia, although they ultimately become frustrated, just like the patient with Broca's, in the beginning they oftentimes try to fake it. So that, let's say I'm Mr. Jones, I'm coming into the ER. You know, someone may say, "Oh, good to see you, Mr. Jones," and he'll smile and say, "Yes, yes." And you might ask him something like, "Well, did you have any difficulty? Did you have any problems getting here or something?" And he may say, "Yes, yes." And so you say, "Well, what kind of problems did you have?" And he'll say, "Yes, yes." In other words, he'll try to communicate. He'll act as if he understands what you're saying, when in fact he doesn't. And at a certain point in the conversation, you'll realize that this guy has no clue what I'm asking him. Okay? And so in the beginning, they try to fake it, but with time, they become just as frustrated as that person with the Broca's aphasia.
What determines if you have like written or verbal receptive aphasia?
Generally, it's the degree of damage. In most cases, verbal precedes any written. Oftentimes, it's limited to a verbal type of communicative disorder. But if it's severe damage, then it extends into the written word too.
So dyslexia might be some like different in wiring. And
I don't understand dyslexia, I'll be honest with you.
Really?
Yeah.
Okay.
You know, so it's not something I ever studied.
Mhm.
And I wonder if dyslexia is more of a, fits into psychological as opposed to true neurologic. You know, I just don't know.
Okay.
I don't know where it falls in the
I was
spectrum.
just curious if it was.
And it's just my ignorance, so I don't know.
Okay.
Okay. Now, we talked about association areas communicating with other areas. Okay? And when they communicate, they do so via tracts, bundles of axons, whether they be myelinated or unmyelinated. So association tracts are those tracts